Okay, good morning and welcome back. Today we're going to continue with the block 3. Remember that we started in block 3, we started with the respiratory system, and then we had one lecture on the cardiovascular system that was about blood. And today we are going to continue with the cardiovascular system dealing with the heart. So I just brought with me an actual human heart that is actually this heart is a plastinated heart. You remember the guy that I showed you his picture before, Gunther von Hagens, who is the one, he's the one who invented plastination in the 1970s. And in plastination, you convert the body tissues into a plastic-like material. So when you're going to feel this, it feels like plastic, but it is not made from a cast. It is actual human tissue that has been converted into plastic material. And I'm going to circulate this specimen and so that you can have a close look at it, and you will find that the heart with the great vessels is almost the size of the closed fist of the owner. And if you exclude the great vessels that are attached to the heart, and you will also notice that the heart is in fact a form of a cone. It's cone-shaped. It has a base and it has an apex. And so this is the apex of the heart. Therefore, the base of the heart, which faces the apex of the heart, is located posteriorly. Okay? So this is not the base of the heart where I'm holding it like that. This is not the base. The heart, this is the inferior surface of the heart. The base of the heart, because it's a cone, like in a cone, the base should face the apex. So here's the apex, therefore the base of the heart is located posteriorly. Okay, you can circulate this. So the heart is the central component of the cardiovascular system, and it propels the blood to the through the blood vessels. It receives the blood from great vessels, as we will see, and then it propels the blood to the great vessels like the aorta and the pulmonary trunk, and it's working 24/7. It pumps over 1 million gallons of blood per year. This is where the heart is located. It is located in the chest, in the middle part of the thoracic cavity, the region that is called the mediastinum. I think we mentioned about the mediastinum before. It is located in between the lungs. The lungs in the thoracic cavity, they are located on the sides, and in the middle is the mediastinum. One of the contents of the mediastinum is the heart, and you can see here that the mediastinum extends from the sternum anteriorly. Posteriorly, it is the vertebral column. So the vertebral column, the thoracic part of the spine, is located posteriorly. So there are two hard structures bounding the heart, anteriorly and posteriorly. We have to remember that when you do cardiopulmonary resuscitation, you are pressing on the sternum, and then the sternum will press on the heart, because behind the heart there is another hard element, which is the vertebra. So it is in the mediastinum between these two solid structures, the sternum anteriorly and the vertebral column posteriorly. And as I mentioned, that the heart is cone-shaped. It has an apex and it has a base posteriorly. I'm going to show that to you in other slides, but this is the general shape of the heart, and it is the size of the closed fist of the owner. I'm talking about the heart by itself, excluding the great vessels, because the great vessels might give, that are connected to the heart, might give a false impression about the size of the heart. Some people would say that the heart, yes?
With the bony structure anteriorly and posteriorly to the heart, does that cause risk during CPR for fractured rib or sternum?
Yes, of course. You have this risk. You have this risk, but the risk is reduced by the presence of the cartilages. The costal cartilages will give resilience to the thoracic wall. So this will reduce the possibility of the fracture. But there is the possibility of the fracture. But I mean, why the heart is compressed? If the heart is surrounded by soft tissues, then the compression will not be that effective. But because of the heart has a heart tissue anteriorly, which is the sternum, it's a bone, and posteriorly there's the vertebral column, and it's located in the midline, not on the sides, because if it's on the sides, it will not be compressed against the vertebral column. So this will give an added advantage for the CPR. Yeah. But does not exclude the possibility of fracturing the rib. And as I mentioned, that some people might say, well, the heart is located on the left side. This is not exactly true. The heart is not located on the left side. The heart is located behind the sternum. It's in the midline. 1/3 of the heart is in fact to the right of the midline, but 2/3 of the heart is to the left of the midline. So most of the heart is located on the left of the midline, but you should keep in mind that there is 1/3 of the heart that is located to the right of the midline. So that's the actual location and the projection of the location of the heart on the surface of the body. And the heart is surrounded by a pericardium. The pericardium is like we call it, sometimes they refer to it as the pericardial sac. So it's a sac, membranes. There are 2 layers of pericardium. There's the fibrous pericardium and the serous pericardium, but it is 3 coverings. So there is two layers of the pericardium, fibrous and the serous pericardium, but the serous pericardium has two layers. I'm going to describe this in a moment. The fibrous pericardium is the outer layer, is the outer sac. As the name indicates, it's fibrous, it's tough, consisting of dense connective tissue, and it protects the heart, it prevents its over distension, and at the same time it connects or anchors the heart in position. Because the fibrous pericardium is in fact fused with the diaphragm, at least inferiorly, the fibrous pericardium is fused with the diaphragm below the heart. Then comes the serous pericardium. The serous pericardium is in 2 layers. Remember the pleura. We mentioned something about the pleura in the first lecture of this block when we were dealing with the lung. We said that the pleura is a serous membrane. There are examples of serous membranes in the body. There is the pleura, there is the pericardium, and there is the peritoneum, which we are going to study with the gastrointestinal system. There is always 2 layers of these serous membranes, parietal layer and visceral layer. In the pleura, we were talking about parietal layer of pleura and a visceral layer of pleura, and between them there is a cavity, which is a potential space containing fluid, serous fluid, which is called the pleural fluid. Exactly the same here in the heart. There is a serous pericardium with a parietal layer and a visceral layer, and in between them there is a potential space. Thin, very thin space that contains serous fluid, which we call it pericardial fluid. And this reduces friction. The heart is always beating, so it reduces friction between the heart and the surrounding structure. And as I said, it's 2 layers. The fibrous layer, the parietal layer of the serous pericardium and the visceral layer of the serous pericardium. Both of them, they constitute the serous pericardium, and in addition to that, there is another coating that surrounds the heart that is thicker coating, and this is called the fibrous pericardium. This is not present in the lung, surrounding the lung. There's no fibrous layer surrounding the lung. It's only in the heart. But surrounding the lung, there is a pleura, serous, which is a serous membrane having a parietal and visceral layers. The same thing here we have in the heart. The visceral layer that is directly applied to the heart is also called the epicardium, because actually it constitutes one of the layers of the heart. So the layers of the heart itself, like the heart that you are holding now, it has 3 layers. The outermost layer, which is a very thin layer, is in fact part of the pericardium. It is the visceral layer of the serous pericardium, and the other name of it, because it belongs to the heart, it's called the epicardium, the outermost layer of the heart. Then Deeper to the epicardium, we have the myocardium, which is the thickest layer, because the heart actually, it's a pump. It requires muscle fibers. So there are thick muscles here. Of course, these are not skeletal muscles. They are not smooth muscles. They are cardiac muscle fibers. So the myocardium is formed of cardiac muscle fibers, and it's a thick layer. It's the intermediate layer. And then deeper to that, the heart is lined with a thin layer, which is the endocardium. Because the heart, actually, it's a blood vessel after all. And the blood vessels, as elsewhere in the body, they are lined by simple squamous epithelium, which is called endothelium. So here again, the heart is lined by simple squamous epithelium, which is called the endocardium. Not only the epithelium, but there is some connective tissue added to it. So 3 layers: epicardium, myocardium, which is the thickest, and then the endocardium. These are the layers of the heart. The heart has 4 chambers, 2 atria and 2 ventricles. You might be sometimes misleaded by some of the simple diagrams of pictures, like especially in physiology textbooks, that will show you that there are 2 atria above and 2 ventricles below. It's not actually like that. This is not the actual or anatomical position of the heart. This is the anatomical position of the heart. The heart is tilted. It's not like the lover's heart that you always draw, but it's something else. The anatomical heart is something different. So saying that there are 2 atria above and 2 ventricles below is not anatomically correct. There are 2 atria, there are 2 ventricles, but as you can see here, that this is the right atrium, this is the right ventricle. The right ventricle constitutes most of the anterior surface of the heart. Now, where's the left side of the heart? The left side of the heart is located more or less posteriorly. So you can only see a narrow strip of the left ventricle here, and you can see a very small portion of the left atrium here. But you will be able to see the left atrium from behind. Okay, because the heart is tilted. It's not actually like 2 atria above and 2 ventricles below. So let's start with the right atrium. The right atrium here it receives the venous blood from the heart. So that's why it's blue. It receives venous blood, deoxygenated blood from the entire body, including the heart itself. As we will see that the heart is always pumping, it requires a very good blood supply, and so the blood should be drained from the heart. Although the heart contains blood inside it, but this blood is not enough to supply the muscles of the heart. The muscles of the heart is thick, so it requires blood vessels to supply it. It cannot depend on the oxygen that diffuses from the blood inside the heart. So that's why we have a coronary circulation, coronary arteries that supply the muscles of the heart, and then we have a coronary vein, a coronary sinus that drains the blood from the heart. So this is received in the right atrium, the coronary sinus that drains the heart itself, the superior vena cava that brings the blood from the upper part of the body above the diaphragm, and the inferior vena cava that brings the blood back to the heart from the lower part of the body below the diaphragm. All of them, so all the venous blood is collected into the right atrium, and then it is pumped from the right atrium through an opening between the atrium and the ventricle. So this opening is called atrioventricular opening. And it is guarded by a valve. So the valve is the atrioventricular valve, because there is another opening on the left side as well. So we have to call it the right atrioventricular opening. And the other one will be the left atrioventricular opening. Now this valve here that guards this right atrioventricular opening is also called the right atrioventricular valve. But because it has 3 cusps, it has 3 leaflets, it's also called the tricuspid valve. So the other name of the right atrioventricular valve is the tricuspid valve. So the blood will flow when the right atrium contracts. It flows from the right atrium to the right ventricle through the right atrioventricular opening that is guarded by the tricuspid valve. Once it's in the right ventricle, this is the right ventricle, then you can see this is the right ventricle. It is separated from the left ventricle by a septum, which is called the interventricular septum, which means in between two ventricles, and the blood that is received from the right atrium will be pumped through this right ventricle. It will be pumped through a pulmonary opening here to the pulmonary trunk, and this pulmonary orifice is guarded by another valve, which is called the pulmonary valve. And this valve has cusps or leaflets that you can see. These are the cusps. They look like half a moon. That's why they are semi-lunar. So they are called the semi-lunar valve. So the pulmonary valve is semi-lunar because it has cusps, 3 cusps that look like a moon, and these guard the opening here. And the blood will be therefore will be pumped from the right ventricle into the pulmonary trunk. The pulmonary trunk divides into 2 pulmonary arteries. These pulmonary arteries will carry the blood to the lung. They are pulmonary arteries, but they carry deoxygenated blood, unlike other arteries in the body. The other arteries in the body, they carry oxygenated blood. But this one carries deoxygenated blood to be oxygenated in the lung. Okay? But they are called arteries in the sense that they carry blood away from the heart. Because an artery, by definition, carries blood away from the heart. And a vein carries blood toward the heart. But it just happens that most of the arteries carry oxygenated blood, except these pulmonary arteries. They carry deoxygenated blood away from the heart. Now, the blood returns from the lung as it's deoxygenated at the as it is oxygenated in the alveoli of the lung. We have mentioned that previously. It returns by pulmonary veins. So we have 4 pulmonary veins, 2 from each lung, 2 on the right, 2 on the left. We have 4 pulmonary veins. These are the pulmonary veins. They are drawn in red because although they are veins, but they carry oxygenated blood, bringing the blood to the heart. Therefore, they are veins, but they carry oxygenated blood, and they open into the left atrium. See, now the left atrium, although it is the left atrium, you cannot see the left atrium from the front, but you can see it from the back. It is actually, the left atrium is the base of the heart that faces the apex, because the heart is cone in shape. So the left atrium is located posteriorly. It is at the base of the heart. This is the left atrium. You cannot see much of the left atrium from the front. If you look at it here, it's only part of the left atrium. But when you rotate the heart, now if you have the heart in your hand, rotate it and look at the back, you will find that the chamber there is the left atrium that receives the 4 pulmonary veins. And the blood from this left atrium will be pumped into the left ventricle through an opening which is called the left atrioventricular opening. And this opening, the left ventricular atrioventricular opening, is again guarded by a valve. As you can see it here, this is the valve. It has 2 cusps. So it is not called tricuspid like on the right. It is the bicuspid valve. So here, the valve is called the bicuspid valve, which guards the left atrioventricular opening. The other name of this valve is the mitral valve, because these cusps, they look like the bishop's mitre. This is the bishop's mitre, so that's the reason they call it the mitral valve, the bicuspid valve. Now, the blood will be pumped from the left atrium, oxygenated blood, through the bicuspid or mitral valve into the left ventricle. You can see that the left ventricle has a very thick muscular wall, and it will pump the blood from the left ventricle to the aorta through an aortic orifice, through an aortic opening that is again guarded by a valve, which is semilunar. So you can see them here. This is the section, we are looking at them from above. So this is the aortic opening guarded by the 3 cusps, semilunar valve, and this is the pulmonary opening guarded by again another semilunar valve. Here you have 1, 2, 3 cusps. That's the tricuspid valve, atrioventricular, and here you have 1-2 cusps, so that's the bicuspid or the mitral valve. As you can see here, that the aorta and the aortic valve, above the aortic valve, there are 2 openings here. And these are the openings for the coronary arteries. The arteries that supply the blood to the muscle of the heart itself, which needs a good blood supply. So the coronary arteries, they arise from the aorta behind or distal to the aortic valve. And the aortic valve, the structure and function of the aortic valve is almost exactly the same like the pulmonary valve. But in the pulmonary valve, we don't have, or above the pulmonary valve, we don't have arteries arising. But here in the aorta, we have coronary arteries, because the arteries, they should supply the muscle of the heart with oxygenated blood, so they cannot branch from the pulmonary trunk. The pulmonary trunk carries deoxygenated blood, so they have to arise from the aorta. Okay? And here you can see the thickness of the heart. The thickness of the chambers, as you might have seen that when you hold the heart with your hand, they vary depending on the function of the chamber. So the atria, usually they are the thinnest, because when the atrium contracts, it just pushes the blood from the atrium to the ventricle, very short distance. They are very adjacent, the atria and ventricle. So you don't need very thick muscle. But the ventricles, you need thick muscles. But even in the ventricles, the right ventricle is pumping the blood from the heart to the lung. So you don't need a lot of force to pump that blood. But it is thicker. This is the wall of the right ventricle. This is a section in the heart showing you the right ventricle has thin wall, but the left ventricle, which when contracts should push the blood to the systemic circulation, and the blood should reach the tip of the toe or the vertex of the head. So that's why you need a very powerful pump, very thick muscles. That's why you can see here that it's almost 3 times as thick as the wall of the right ventricle. It is the thickest chamber of the heart, the left ventricle. And when in this cross section, sometimes it's described like a croissant donut. This is the donut, the circular, thicker part here, and this, which is the left ventricle, and this one is the right ventricle. It is crescentic in shape, and it is thinner than the left ventricle. And this is, again, to show you how the blood is circulating within the heart. So we will start with number 1 here. That's the right atrium, collecting blood from superior, inferior, and inferior vena cava, as well as from the coronary sinus, which drains the muscle of the heart itself. It pushes the blood through the right atrioventricular orifice, which is guarded by the tricuspid valve, and then to the right ventricle. Right ventricle here pushes the blood, deoxygenated blue blood, through the pulmonary trunk, and this is guarded by a valve, which is semilunar, pulmonary, and then to the pulmonary arteries. It will go to the lung, become oxygenated in the alveoli, and return through pulmonary veins. They are drawn in red because this blood is oxygenated. 2 on the right, 2 on the left, and the blood will be returned to the left side of the heart, left atrium. From the left atrium, contraction of the left atrium pushes the blood through the left atrioventricular orifice that is guarded by the bicuspid valve or mitral valve into the left ventricle, the thickest wall here, which pushes the blood through the aorta, ascending aorta. And as the blood is pushed into the ascending aorta, it will nourish the muscle of the heart, because from the ascending aorta, coronary arteries arise. These are the valves. This is to show you how the valves are working. This is an example. Let's say this is a bicuspid or a tricuspid valve. And when the atrium contracts, it pushes the blood through the opening. But when the ventricle contracts, a contraction, we call it systole, and relaxation is called diastole. So when the ventricle contracts, then the valves, these cusps, they will the atrioventricular cusps, they will become everted, they will go up, but they will close as they go up. They are prevented from being everted because they are held down by these cords. It's like the strings of a parachute. So they are pulled down, prevented from being prolapsed up. And so the valve will close, okay? And during ventricular contraction, because when the ventricle contract, you don't want the blood to return back to the atrium. You want the blood to be pushed either into the pulmonary trunk or into the aorta. The blood should not return back to the atrium. So these cusps will close, and the regurgitation of blood or eversion of these cusps is prevented because they are pulled down like a parachute by strings which are located in the ventricle. And this is the semilunar valves. They have another mechanism to open and close. You can see here that they are opened during ventricular diastole. When the ventricles contract, both of them are opened. The aortic and the pulmonary are open. And then when the ventricles relax, blood tries to return back to the ventricles. And as it returns back into the ventricles, it will pass in pockets behind these semilunar cusps and will push them close. So it's like you have the blood returning back into a pocket, and it will be pushed. And so these pockets will come together and close the valve. So there are no strings here. It's another mechanism of closure. It's rather a passive mechanism of closure. And when these valves, they close, they will produce a sound. This is what we call the heart sounds. First and second heart sounds. This is another flow chart showing you the blood circulation. I think we went into the details, so you can study that by yourself. Just to show you here that this is the what we call the systemic circulation, where the blood is pushed from the left ventricle to the aorta and its branches. And these branches will branch and branch, become smaller. As we will see next time when we deal with the vessels, we have arteries, and then the smaller arteries, which are called arterioles. And then the arterioles become smaller and smaller, and then they give rise to the capillaries. This is where exchange of gases takes place, the thinnest of the blood vessels, and then the capillaries will collect and form small veins, which are called venules. The venules will form big veins like the superior vena cava or inferior vena cava that return back to the left atrium. And this is the other circulation, is the pulmonary circulation, where the blood is pushed from the right ventricle to the lung, oxygenated, returns via pulmonary veins to the left atrium, and from the left atrium to the left ventricle, starting the systemic circulation. So the two circulations are going on at the same time, and in addition we have these coronary arteries and coronary circulation. The coronary circulation supplies the muscle of the heart itself. The coronary arteries, right and left coronary arteries, they surround the heart like a crown. That's why it's called coronary. And they anastomose. We will talk about anastomosis next time as well. And anastomosis means that when there are multiple arteries supplying the same area and they are connected with each other. So when you have an anastomosis, you are on a safe side. Why? Because when one artery is closed, then the other artery can compensate. Okay? It's not like you have what we call a cul-de-sac or a dead-end street. It's not like that. If one side of the street is closed, then you can approach your house from the other side. That's an anastomosis. So having an anastomosis is good. And in the heart, as I mentioned, because the atria should contract, and then the ventricles should contract, all of this should be synchronized. And this is done by what we call a conducting system of the heart, or conduction system of the heart. And this coordinates the contraction of the heart muscle. This conducting system is a specialized cardiac muscle. They are not nerves, they are not cardiac muscle, they are modified cardiac muscle fibers. We have dealt with cardiac muscles before. You remember the cardiac muscle, it's a striated muscle, but it's involuntary. It has a central nucleus, one nucleus, unlike the voluntary striated muscle, the skeletal muscle, which has multiple nuclei that are located in the periphery. The cardiac muscle is branched, and remember that the cardiac muscles are connected to each other by what we call intercalated discs. We mentioned that probably in the first block of this semester, and these intercalated discs contain gap junctions, which allow the muscles communicate with each other chemically. Chemical and electrical communication between the muscles through these gap junctions. So these muscle fibers, they act like what we call a syncytium, or like a network together. They act together. Modified cardiac muscle fibers produce the conducting system of the heart. And this system starts here at a node, an area in the wall of the right atrium, which is called the SA node, or the sinoatrial node. Either you say SA or the sinoatrial node. You can use the SA only. So the SA node is located in the wall of the right atrium, and it triggers, it fires electrical impulses at a certain rate, and it's controlled by autonomic nerve fibers, but it has its own rate of triggering. So it triggers electrical impulses, and these impulses are going to be distributed in the atria. They propagate in the atria, and the atria will contract at this rate. So this SA node is also called the pacemaker of the heart, because it creates the pace of contraction of cardiac muscles. And then these impulses, these electrical signals, will reach another node here, which is located in the septum between the two atria, called the interatrial septum, very close to the ventricles. And so this is called the AV node, the atrioventricular node. And so when the impulses reach the atrioventricular node, it will fire again. Okay? If it doesn't receive impulses from here because of a disease of the heart, which is called heart block, then this atrioventricular node has its own rhythmicity. It can fire, but the rate is much slower than the rate of the SA node. So it fires like about a rate of 40 per minute, which is most of the time not enough for the heart. Okay? And then from the SA node, the impulses will be transmitted by a bundle, which is called the atrioventricular bundle of His, a person named His. So atrioventricular bundle, and this will be divided into right bundle and left bundle branches, and will be distributed in the ventricles, and then they will be continued as tiny muscle fibers, modified muscle fibers called Purkinje fibers. So by this way, the impulse is propagated in a synchronized way, starting with a firing of the SA node. The impulse will be propagated in the right atrium contracts. There will be a pause in the atrioventricular node, then the atrioventricular node will fire, and the impulse will be distributed in the ventricles, then the ventricles will contract, and then returning the cycle again. And these electrical signals can be recorded by using the ECG. These are the parts of the ECG. You don't need to go much into details of how this is taking place, because this is more or less more physiology than anatomy. But these are the parts of the ECG. This is the P wave, which shows you the depolarization of the atrium, and then this is the depolarization of the ventricle and this is the repolarization of the ventricle. The repolarization of the atrium is somewhere here. It is hidden and obscured by this wave, the big wave, which we call it the QRS complex. Okay? And if, as I said, if there is anything wrong with this conductive system, this might result in either fibrillation, excessive contraction, excessive triggering, or it might result in block. And in this case, like in case of block, in heart block, nowadays they are using what we call artificial pacemaker. And this artificial pacemaker is installed on the under the skin of the thorax, and there are leads here. Electrical leads are passed through the veins. It's battery operated, and they are passed through the veins. You can see here, this is the subclavian vein. You don't need to go into details, but just to show you this as an example, here's the subclavian vein. It's just under the clavicle here, and can be easily entered by the lead, and then this will be introduced into the superior vena cava, right atrium. You can see it here. One of the leads is inside the right atrium. The other continues here through the atrioventricular opening into the right ventricle. And these will trigger instead of the SA node or the AV node. So they will produce an artificial pacemaker instead of the natural pacemaker. The natural pacemaker, remember, it is the SA node, which is modified cardiac muscle fibers located in the wall of the right atrium. And this is about auscultation. Auscultation is the listening to the heart sounds, and you usually use the stethoscope. This is Laennec, the French physician who first invented the stethoscope to hear the sounds of the heart and the breath sounds. Before that, this is called indirect auscultation. Before that, the physicians, they used to do what they call direct auscultation. So they put the auricle of the ear directly on the chest of the patient. But this guy, because he was embarrassed while he was examining a young lady, so he decided to roll a piece of paper and put it away from her chest and here, and then he discovered that the sound is much better in this case, so he invented the stethoscope, and that was the earlier stethoscope invented by him, Laennec. So auscultation, you hear the heart sound. These heart sounds are produced by closure of the valves. When the valves are closed, they become tense, and so they produce a sound. So we have first heart sound, which is produced by the closure of the atrioventricular valves, the bicuspid and the tricuspid valve, which usually it is heard as lub, and then the dub, which is the closure of the aortic and pulmonary valves. So lub, dub, lub, dub, lub, dub. That's the how the heart sound is heard when you put a stethoscope on your chest or the chest of a patient. The second heart sound is created by closing of the semilunar valves, which are the pulmonary and the aortic valves. As I said, that the heart rate is regulated by the SA node, and the SA node itself is regulated by the autonomic nervous system. So whenever there is increase in sympathetic impulses, this will increase in the heart rate and the force of contraction. I think we mentioned that when we were dealing with the nervous system in the previous block, in block 2, and also we mentioned it when we dealt with the endocrine system. So it increases the heart rate. The sympathetic increases the heart rate and force of contraction. Parasympathetic reduces the heart rate. And there are certain baroreceptors which sense the blood pressure. That's why they are called baroreceptors, like in barometer. So baroreceptors are located in the aorta and in the carotid arteries, and they detect changes and they can alter the nervous control. Also, the heart is affected by hormones, ions, age, gender, physical fitness. Like a person who is very fit physically, usually they have a lower heart rate. people who are the athletes, they have lower heart rate. And this is to show you about coronary artery disease, because as I said, that these coronary arteries that supply the muscle of the heart are very important, because the heart requires oxygen, and they are small arteries in fact, and they can be easily blocked, although there is an anastomosis which is good, but in most of the time this anastomosis is insufficient to supply the cardiac muscle. So you have an alternate route, but that route is small. It's not enough. That's why this results in reduced oxygen to the heart muscle, and this produces what we call ischemia, reduced oxygen supply, ischemia, and results in pain in the heart, which is called angina pectoris, or it might result in death of the cardiac muscle. And the cardiac muscle cannot regenerate, as we have mentioned before. They cannot regenerate. So they will be replaced by fibrous tissue. And the problem will be accentuated if part of the conductive system will be involved in this infarction. So infarction is a step forward. It's more dangerous than angina pectoris, because there is death of cardiac muscle fibers. Here, as you can see, this is a normal coronary artery, and this is a stenosed or narrowed coronary artery. It's obstructed by what we call atherosclerotic plaque, like fatty material that deposit in the artery and cause its narrowing. Sometimes it's a spasm of the artery that results in narrowing. So the amount of blood reaching the heart muscle is less than the amount of oxygen, let's say, reaching the cardiac muscle is less than the amount that the cardiac muscle requires. And so this will result in accumulation of metabolic products in the cardiac muscle, resulting in pain. This is triggered by accumulation of chemical material inside the muscle. If no oxygen is reaching, then the cardiac muscle will die and will be replaced by fibrous tissue. You can see here, this picture, it summarizes the risk factors of coronary artery disease. Usually it's a man, like 60 years old, probably here, an old man, doing like physical exercise. He's a smoker, carrying heavy weight, and leaving a restaurant after a heavy meal, and it's a very cold weather, so which requires more circulation of the blood. So all these, the blood is cannot, or the coronaries cannot compensate enough oxygen for the excessive work that is required for the heart, and this results in pain in the heart. Usually the pain is in the chest and will be referred to the medial side of the upper limb. And to treat these coronary artery disease, there are a lot of methods of treatment, including drugs and including what we call an angioplasty. Angioplasty here, you pass a catheter. The catheter is passed through the femoral vein and introduced up into the aorta, up into the arch of the aorta, ascending aorta, and then you can enter the coronary arteries, which are branches of the aorta. Of course, this is under X-ray control, and the catheter here reaches the site of the narrowing, and then a balloon is inflated. This is what we call angioplasty. You inflate a balloon, and then you deflate it and go out. Or sometimes they leave a mesh work here, which is called stenting. It's a mesh which keeps the artery open. If these are not enough, then they can do what we call a bypass grafting, coronary artery bypass grafting, a cabbage operation, they call it. They will bring a vessel directly from the aorta into the coronary artery, distal to the site of the obstruction. This is the site of obstruction, so they will bypass the site of obstruction, coronary artery bypass grafting. And this is just to show you the importance of these coronary arteries and the function of the heart. The heart cannot depend on the blood that is located inside its chamber because of the thickness of the wall of the heart. After all, it's not a blood vessel, it's a pump. It's a modified, a thick blood vessel. Questions? Thank you.